So, Assalamualaikum warahmatullahi wabarakatuh. My name is Alia Shanis binti Muhammad. My metric number is 080357. So, today I will represent about radiographic image analysis of the kidney stone, which is demonstrated in the KUB view, which is the kidney ureter bladder view of X-ray. So here we have the table of content, which is starting with introduction, sign and symptom, projection and position, anatomy, alignment, collimation and exposure, marker, aesthetic, name and conclusion. So we are continuing introduction. Kidney stone or renal calcula is hard deposit that form in the kidney from the sterilization of mineral and salt in the urine. The risk factor include excessive calcium intake, chronic ETI, which is we know as urinary tract infection. This condition is common in the man, especially is over 30 years old, and most stone is developed in the renal calyx or renal pelvis. Next, we are going to the sign and symptom. First is a frequent urination, second is nausea or vomiting, and then pain or burning sensation while urinating, and always fever and chill. So now we are going to continue about the PACEMAN. First P is a projection. This is an AP supine abdomen KUB, or we know as a kidney ureter bladder view X-ray. It is because to identify urinary stone, which is the kidney stone, bladder stone, or any blockage along the renal tract. It also provides the baseline information about the shape, size, and position of the anatomy. And it is also to ensure urological stand, for example, is judge's stand and the catheter are placed correctly. For the second P, we are the positioning. There are the positioning error of the rotation evidenced by the left iliac wing is larger than the right side, and the distance from the spinous process and the pedicle are not equal distance. Left atrial spine also demonstrated slightly without pelvic vein superimposed. They also have a little bit tilting error, which is the right side iliac wing is appear little bit higher than the left side. For the improvement, we have the patient can be improved by ask patient to rotate to the right side slightly until the MSP perpendicular to the IR, and then check the axis by the palpating the axis and ensure they are equidistant. And before we start to expose the exposure, we should pull gently patient leg to straighten the patient. So now is A. A is for anatomy, so we have the ribs, lumbar vertebra of L4, right sacroiliac joint, right femoral head, left kidney stone. For the stone is appear more whiter than the bones. And then we have a left psoas muscle, left axis, sacrum, and acetabulum. For the axis, it is the anterior superior iliac spine. So now we have another A, which is the alignment. First is the extrude and the patient. Second is the extrude and the image receptor. Both of these alignment cannot be determined because there is no foci collimation. The third is image receptor and the patient. There is misaligned between the IR and the patient, where the centering is correct at the level L5, but this is rotated to the left side. So now we have a C. C is for collimation. The good collimation of AP supine KUB view should include superior border of the upper kidney pole, inferior border is inferior pubic rami, and lateral border is lateral abdominal wall. For this radiography is adequate collimation and centered at the level of iliac crest, which is L5, and there is no foci collimation. And we have a E. Is a E for the exposure. The normal range of exposure is 75 until 85 kVp and 20 to 50 MAS. For the KVP for this radiography is good because the cortical outline of the thick sacrum and thin structure of ilium can be seen, and for the MAS is adequate because the bony pattern of the thick structure of sacrum and also the thin structure ilium can be seen. So now we move to the man. So what is a man? M is state for marker. There is a marker R to indicate R of the abdominal area, which is the right abdominal area. The marker also not superimposed with important structure. The now is A. A is aesthetic. The film size is 35-43 cm and orientation of this film is lengthwise. There are also no motion evidence by any artifact, and the bony structure and the soft tissue are clearly visualized. And lastly, we have an N. N is the name, which is the name of the patient, the register number, RN, or we call the ID patient, are not visible. It also should be located upper or lower border of collimation with not superimposed with important structure. For the conclusion, I reject this AP supraabdominal KUB view X-ray is because there is no patient ID, which is essential to clinical practice, and they have a slightly rotation where can be error measuring the size of stone. So now we move to the second PACEMAN. P is a projection, like I told earlier. The AP supraabdominal KUB is for identifying urinary stone, provide baseline of the size, shape, positioning, anatomy along the renal tract, and to ensure that a urological stand or catheter are placed correctly. And for another P is for positioning. There is a positioning error of rotation evidenced by the distance from the spinous process and pedicle not equidistant, but in the pelvic region is not appear obesity of the rotation. The positioning can be improved by aspiration to slightly rotate it to the right side until the MS to be perpendicular to the IR, and then check the rotation by perpetuating axis and ensuring they are equidistant. Also, a slight curve of the lumbar spine is demonstrated. The pelvic appears relatively symmetrical with no significant evidence of the patient rotation. Such as we can see, they have no appear of the ischial spine not superimposed with the pelvic brain. And then therefore, the lumbar deviation may represent the patient anatomical variation such as scoliosis rather than a positioning error. So now we move to the anatomy. So we have the ribs, lumbar vertebra L4, right iliac vein, sacroiliac joint, right sacroiliac joint, symphysis pubis, left kidney stone, left psoas muscle, left axis, sacrum, and left acetabular. Alignment of the extractor and the patient is aligned because the center is fall on the level of the iliac, which is the L5. And for the alignment of the extractor and the image receptor is aligned because inferior and superior border is equidistant and both lateral border is equidistant. And then for the image alignment of the image receptor and the IR is also aligned because it's centered at the level of iliac crest and L5. The correct dimension of episopal KUB view is should be include superior border is upper kidney pole, inferior border is inferior pubic rami, for lateral border is lateral abdominal wall. And this radiography is adequate collimation, and the center is at the level of the iliac crest, which is L5, and there is a four-side collimation. For the exposure, the normal range of exposure is 75 to 85 kbp and 20 to 50 MAS. The kbp of this radiography is good because the cortical outline of the thick sacrum and thin structure ilium can be seen. For the MAS is adequate because the bony structure, for the bony pattern of the thick structure and sacrum and thin of ilium can be seen. There is a marker L to indicate left of the abdominal area, and the marker are not superimposed with the important structure. And last but not least, we have the A. A is the aesthetic, which is the fillet size used in 35-43 cm, and the orientation is lengthwise. There are no motion evidence by any artifact, and the bony and the soft tissue are clearly visualized. Lastly, we have an N, which is the name. The name of patient names and the register number RN or ID patient, date, the institution, hospital, clinic name are not visualized in this radiography. The name should be located in the upper or lower of the collimation border without superimposed with important structure. For the conclusion, I reject this episode by abdominal KUB view X-ray because there is no patient ID, because it is essential in a clinical practice, and they have a slightly rotation where can be error in measuring the shape or the size of the stone. So that's all for me. Thank you.